Hello, I'm Rae-Grant, staff neurologist at the Mellen Center for Multiple Sclerosis at the Cleveland Clinic. As part of the MS Highlights 2015 program, my job is to present best practices for the busy clinician expert recommendations. This information encapsulates a number of themes from the Consortium of Multiple Sclerosis Centers meeting held in May of 2015. This was a very useful interdisciplinary meeting which involved many practitioners working with people with multiple sclerosis. A number of themes emerged from this conference. First of all, the critical theme that multiple sclerosis is a longitudinal condition. In this case, people with MS touch multiple practitioners in multiple care settings. And it's very important for clinicians working with people with MS to address multiple medical, social, and psychological issues in different care settings. It really requires a systematic approach to longitudinal care, which is quite different from most of the care that we provide in medicine. There were therefore a number of presentations relating to provision of care, either the environment of care, methods of care, or novel care activities during the conference. If you're an MS clinician, it is worth taking time to reflect on these issues to consider modifying the care that you provide. I pulled out a number of abstracts from the meeting which dealt with care environment and methods. These are by no means all of the abstracts. For example, Bromley did a study on dietary interventions that may have an impact on fatigue and measures of health, such as the short-form health survey. This was a preliminary study on 6 patients, but really focused deeply on case files and dietary indiscretions that may affect fatigue and lower perception of health. What this really reinforced was looking into diet in people with multiple sclerosis as part of their longitudinal care. Anderson et al. Presented the day program in a novel outpatient setting. This was an interdisciplinary program for people with multiple sclerosis and other clients with neurodegenerative disease. They focused on more severely disabled clients and a structured day program which facilitated socialization in these patients. This reinforced the role of teamwork, particularly as people with multiple sclerosis have more needs and more barriers to mobility and activity later in the disease. Dr. Rensel et al. From our center did some work looking at wellness practices in people with multiple sclerosis. They surveyed over 100 people with MS about their wellness activities. They found that most had used nutritional wellness approaches, about 3/4, or had used a health management tool of some kind. In addition, about 40% had used supplements during their time with multiple sclerosis. People with MS appear to be aware of wellness options and want to know more about these options for their longitudinal care. The other presentations I've listed also focus on what we can do to modify the longitudinal care environment. For example, Eustace presented a case report of a severely affected female where ongoing mentoring and journaling was used to improve exercise and the perception of self-efficacy. Vincent et al. Used iPad and Fitbit methodologies to improve distance rehabilitation in their people with multiple sclerosis. In our center, we've begun using iPad apps and telemedicine visits to extend our reach and improve longitudinal care. Hera Cleaver from our center developed a pre-visit nursing phone contact to ensure that out-of-state patients got the appointments they needed with different members of our team, avoiding the need to go back and forth for more visits. Finally, Marks et al. Reviewed emotional support programs to support people with multiple sclerosis. Critically important given the 50% lifetime incidence of a major depression in this population. There are a number of presentations on epidemiology of genetics, and I just pulled out one which reminds us of a very important point. This looked at the clinical course of relapsing, remitting multiple sclerosis patients in non-white MS patients. And Williams et al. Analyzed baseline and clinical course of a placebo arm of 6 trials by racial and ethnic groups, and you can see the listed trials. The study confirmed previous observations that African American or Black subjects had a higher risk of EDSS progression, that is disability progression, during the study, and a significantly greater mean change from baseline versus white subjects in their score at 1 year. These results highlight the need to increase recruitment of non-white subjects into MS clinical trials to gain a better understanding of disease activity and response to disease-modifying therapy. It is also a challenge for clinicians to consider individualizing treatment approaches due to different disease course in different individuals. We can't use the same paradigm for all of our patients. There are a number of studies looking at quality of life outcomes. As we all know, we tend to use disease-based measures in terms of outcomes for MS trials, but increasingly outcomes that matter to people with multiple sclerosis are outcomes that should concern clinicians. These are drivers of true disability such as mobility, cognitive impairment, bowel and bladder control, pain, and emotional disorders. In addition, issues such as quality of life and particularly employment status need more of a focus. Another issue of treatment is a preference to different kinds of treatments and approach to treatment which is sensitive to personal, cultural, racial, and other patient-specific factors. Going forward, it looks like endpoints for studies that incorporate these factors will receive more attention in decisions on care. One example looking at this is by Goldman et al., looking at the association between measures of disability and employment in secondary progressive MS. And this was baseline data from a large multi-center trial. And they reviewed clinical and patient-reported outcomes and their correlation with employment. At baseline, about 38% of secondary progressive MS patients enrolled in the study were employed, while 62% were unemployed. And as one might predict, at baseline, unemployed subjects had longer timed 25-foot walk times, worse MS walking score 12 times, and worse EDSS scores than employed subjects. In addition, employed subjects had better 6-minute timed walk, better Abelahan measures, 9-hole peg test measures, and symbol-digit modality test scores. And in the cognitive impairment composite subgroup, better composite cognitive endpoints. This really focuses on thinking about quality of life measures as well as disease-based measures to inform our decision-making and also the significant impact that these have on employment. An interesting issue in care right now, as we have more long-term experience with disease-modifying therapy, is when do we stay with a medication and when do we switch and what do we switch to? These are continuing to be open-ended questions with answers that are incomplete. However, the database on these is increasing, and we are getting more and more information on when to switch, what to switch to, and what happens when patients switch. At this meeting, various presentations added to this present data on these crucial treatment questions. For example, one study, a single-center study, looking at the safety and efficacy of switching from natalizumab to dimethyl fumarate was presented by Amjad and al. So they looked at 66 patients who underwent this switch. 71% remained clinically stable, but about a third were unstable with new disease activity after the switch. We certainly know this is one of the risks of switching from one medication to another, particularly from natalizumab to other agents. A multi-center study supported by Biogen, presented by Cohan et al., was looking at real-world outcomes in relapsing patients who switched from natalizumab to delayed-release dimethyl fumarate. This reviewed experience in 50-plus centers and 500 patients. This again showed similar findings, but did focus on the lower rate of discontinuation of dimethyl fumarate at 1 year than in many other clinical trials, about 17% at the end of 1 year. This is a bit encouraging to tell us that people do tolerate this reasonably well. However, again, about a quarter of patients developed new disease activity during this time. Over time, we're learning more about the risks and benefits of switching. This will probably be a more nuanced judgment than just stopping people after 2 years on natalizumab or if they become positive with a JC virus antibody. We will probably need to look hard at disease activity rates after switching for as many agents as possible so we understand the risks. In addition, we do need to factor in the activity of disease before natalizumab, which is probably quite predictive of activity rates after discontinuation. I think we haven't finished this discussion, and we have more learning to do in terms of what to do next and how. So I would ask you to think about these studies we've talked about. Will they influence your practice? 100 being absolutely, they'll change my practice, and 0 being they will not change my practice. Let's turn to symptom management in multiple sclerosis. We know that working in an MS center means managing symptoms over time. In fact, I would say at our center, we do more symptom management than we do disease-modifying therapy management. Really, the symptoms tend to dominate clinical conversation. Pain, fatigue, cognitive impairment, numbness and tingling or other paresthesias, bowel and bladder dysfunction, these are all key parts of the MS picture. We need to do a better job of attending to symptom management, and I think that this will improve quality of life and possibly employment, both critical issues for people with multiple sclerosis. I pulled out a few of the symptom management references for this slide. So Asamoah et al. Reviewed pain management in multiple sclerosis. I think a key take-home point here was the lack of efficacy of nonsteroidals and opioids in MS-related pain. In fact, there is data to support the idea that opioids may increase central sensitization in this population, leading to a vicious pain cycle. At our center, we tend to try to avoid opioids for chronic pain management in the MS population. Asamoah described 2 kinds of pain in multiple sclerosis: nociceptive pain, which is pain caused when special nerve endings called nociceptors are irritated. And this pain is the kind of pain you feel when you burn yourself, twist your ankle, or stub your toe. Often dull or sharp aching pain can be mild to severe. Asamoah et al. Recommended tricyclic antidepressants, SNRIs, topical lignocaine, or calcium channel alpha-2 delta subunit ligands for these kinds of pain. They noted that sometimes patients need multiple medications for pain control. Neuropathic pain is caused by a malfunction of the nervous system due to illness or injury. These can be sharp, intense, shocking, or shooting pain. They recommended use of antispasmodics, muscle relaxants, benzodiazepines, and anticonvulsants, sometimes in combination. Comer et al. Commented on a retrospective study in people with multiple sclerosis starting on dalfampridine. While most who responded with improved walking speed did not comment on other benefits, other patients, including non-ambulatory patients, noted improvements in domains of function such as stamina, stability, and upper extremity function. I think this indicates that more work is needed to consider other functional benefits of this medication and other related compounds in the pipeline. The last 2 papers focused on known side effects of MS, sleep disruption and sexual disruption. These are very frequent problems, and in our clinic, these are both on the list of topics we evaluate with people with MS, if not every time, then on many occasions. Exercise programming people with multiple sclerosis is more and more important. This is a critical aspect of our counseling with people with multiple sclerosis. I just listed some references from the rehab section of the meeting, which again reinforced the utility of a variety of exercise programs. It probably doesn't matter what specific exercise program occurs, as long as there is some kind of resistance component and some kind of aerobic component to this that's programmed to meet the person's needs. So to summarize, engaging with people with multiple sclerosis is occurring at multiple sclerosis and occurs at multiple levels: system, personalized, symptom, disease, cognitive, rehab, and lifestyle. We need to think systematically about longitudinal care and not just the episode of care that we are in. We do need to find a way to have our patients be active and engaged and understand their disease and what they can do. And it's clear that these will increase the likelihood of better outcomes as measured by quality of life, employment, and other functional outcomes. Thank you for your attention for this program.